welcome, Dr. Lipman. Thank you for making the time in your busy schedule to be able to speak on a very important topic that we are here today for, which is fibroids and, uterine fibroids and how that obviously impacts on nearly, 80% of women that are affected by these. So before we obviously continue with the conversation in our podcast, I would just like to turn it over to yourself to provide a bit of an introduction to our listeners and our viewers on your background as with regards to interventional radiology and your practice, and then we could, go ahead with the conversation piece.
Great. Well, I appreciate you having me. My name is Dr. John Lipman. I am the founder and medical director of the Atlanta Fibroid Center. I've had the pleasure of caring for women suffering with fibroids for the past 30 years. All I do is care for women with fibroids. I don't do anything else. I'm also the founder and chief medical officer of Image Fibroid Centers, and we have a number of fibroid centers now throughout the country. Fibroids are, as you mentioned, an extremely important health issue. It's a silent epidemic. It's been going on a long time. Women have been suffering with fibroids and really haven't been given the appropriate treatment options that are readily available and have been available for quite some time. I did my medical training at Georgetown. I then did my radiology residency at Harvard at Brigham and Women's Hospital, and then did a vascular and interventional radiology fellowship at Yale. And I then moved to Atlanta and have been in Atlanta since 1991.
Fantastic. Well, that's quite a pedigree that you have there, Dr. Lipman, from an academic background, as well as, if you look at some of the institutions you're mentioning with Harvard and Brigham, Brigham, as well as with regards to Yale. But I'm so glad that, you are speaking of this today because, rightfully so, you mentioned something that doesn't get a lot of attention when we speak about uterine fibroids. And hopefully, having experts such as yourself speak more about this will provide that education piece that has been lacking for so many years out there for women that are having to undergo this and did not have the proper resources or an understanding thereof regarding uterine fibroids. So to kind of kick things off, Dr. Lipman, I would like to start at the beginning. If you can kind of explain to us what are uterine fibroids and what basically causes them to develop.
Well, fibroids are the most common pelvic tumor seen in women. As you mentioned, it's common in all women, but it's particularly common in women of color. At least 80% of adult African-American women have these benign tumors. They're a tumor, they're benign, but they can cause a lot of misery. It's the number one reason why women have heavy periods, and unfortunately, it's also the number one reason why women undergo hysterectomy. And one of the most important things that we can talk about is that hysterectomy, while it's an option for women suffering with fibroids, it should be the option of absolute last resort, and in my opinion, is largely unnecessary because we have such outstanding, less invasive treatment options, most notably uterine fibroid embolization, or UFE.
Fantastic. Like you mentioned UFE. I know sometimes it's also referred to as UAE,
Right.
uterine artery embolization. But, you hit on a few very important points there, Dr. Lipman. And one of the things I'd like to kind of get a bit of an elaboration from you and an explanation thereof are the common symptoms associated with fibroids in women.
Yes. Well, fibroids cause their symptoms based on location in the uterus. They're very hard and firm tumors, and they press on whatever's next to them. So there are three main locations of fibroids in the uterus. There are the ones that lie just underneath the lining of the uterus. They're called submucosal fibroids. They cause the heavy bleeding. There are ones that are on the outer peripheral aspect of the uterus, right underneath the outer covering. Those are called subserosal fibroids, and they cause the bulk-related symptoms, the pain, the urinary frequency, the constipation. So fibroids in the front of the uterus will press on the bladder. Fibroids in the back of the uterus press on the colon, laterally press on the pelvic nerve. So the bulk-related symptoms are often due to these subserosal fibroids. And then you have the most common type, which are the intramural fibroids. Most of the uterus is muscular, 95% or more of it. And these intramural fibroids are located in the muscle, and they can cause their symptoms depending on which way they grow. If they grow inwardly toward the cavity and lining, they tend to cause more bleeding issues. If they tend to grow outwardly into the suburbs, like the subserosal variety, they'll cause more bulk-related symptoms, or they can grow in both directions and cause both.
Okay, very interesting because, that's, I think, an important topic because we talk about the different types and actually the impact or effects of those different types. And with regards to that, you mentioned the different types, Dr. Lipman, but what about, does location of the fibroids is as important as the size of the fibroids that are impacting women? Because we spoke about those that impact, the bleeding. You mentioned the submucosal, the subserosal, the intramural. Is location and size, do they go hand in hand? Or is there something that, we should not be too concerned about if we are experiencing that as a woman?
Location is actually more important than size. You can have a very large subserosal fibroid out in the periphery causing no symptoms at all. And you can have a very small fibroid, the size of a pea, or a very small central fibroid, submucosal fibroid, that causes horrific bleeding. So it's really all about location, but size does play a role. The bigger the fibroid in general, the more likely it's going to be causing symptoms, and just press on whatever's next to it. But of the two, location's more important.
Okay, interesting. And with regards to that, how are these fibroids diagnosed, Dr. Lipman? I know that you're obviously an expert in this space, and if a patient were to come over to you, what would be the process that they would encounter to determine a diagnosis of this?
Well, a lot of these women have had the diagnosis made by their gynecologist, family physician, let's say, and that typically meant that they were talked to, they got their history taken by them, they were examined, had a physical exam, and you can feel these fibroids on physical exam. As I mentioned, they're hard and firm, they're like rocks, and so patients can even feel them, particularly when they lie in the front part of the uterus. And as the uterus grows with these fibroids, they will be described as a certain size pregnancy. So a uterus that is enlarged by fibroids up to a patient's belly button is the same size as a 16-week, 4-month pregnancy. So they're discovered oftentimes on physical exam, whether it's by the patient or whether it's by the gynecologist. And then the next thing that's often done to confirm what they really suspect is being fibroids is an ultrasound. Pelvic ultrasound done transabdominally and transvaginally will detect these fibroid tumors. When they come see us at the Atlanta Fibroid Center, we get even higher resolution imaging. Ultrasound is okay to confirm the diagnosis, but we need more information, and that's provided by magnetic resonance imaging, MRI, which has a way higher resolution capability than ultrasound. And it is very important because sometimes the MRI completely changes your approach, or in some cases, patients may either disqualify based on the MRI, or we may recommend something different. So the MRI is really important, and I think more and more gynecologists are starting to see the value of MRI. They all have ultrasound in their office,
Right.
so they get ultrasound, and that's fine, but MRI is worlds better and really should be used more frequently.
Okay, very interesting. So that's another level of, imaging and scans that will be required rather than just solely relying on an ultrasound. With the MRI being able to tell a much more detailed picture in terms of that particular diagnosis. So I think that's important to take away.
And one other thing to mention about MRI is that, we often see people that have what's called adenomyosis, which
Right.
causes symptoms very similar to fibroids, pain and bleeding. In general, adenomyosis patients complain more of the pain than the bleeding, but both are bad. And fibroid ladies often tend to complain more about the bleeding than pain, although, again, both are often bad. But um, adenomyosis is when the lining cells of the uterus, that's called the endometrium, when those lining cells infiltrate into the muscle. And why that's important is that um, adenomyosis is often not diagnosed on ultrasound because the resolution isn't good enough. And that can change the approach and how you treat these patients. And so knowing what you really have, because we've seen patients that have the diagnosis of fibroids based on physical exam and ultrasound with the gynecologist, only to tell the patient they don't have fibroids, they actually have adenomyosis. And that changes the discussion a little bit.
Okay. Now, it's interesting when you compare the fibroids, now that you mentioned it, to adenomyosis, because that's, I think, something that's very, very important for our listeners and our viewers to understand, because, you mentioned one is the bleeding, one is the pain, and why it's so important to get the proper diagnosis detected through the MRI. Before I kind of go down the road where we can talk a bit more, Dr. Lipman, about, uterine fibroid embolization versus hysterectomy, I would first like to, just indicate something that I think is very important. Can these fibroids that are occurring in that pelvic area or in that uterus, can they affect fertility or pregnancy?
Yes. While most women that have the diagnosis of fibroids will have uneventful pregnancies, fibroids can interfere with any part of the fertility journey, from fertilization all the way to delivery. So the answer is yes, they can. And so it's really important to know kind of what you're dealing with. And that's where, as I say, the best imaging available is MRI.
Okay. I think that's important, because that was something I was going to basically ask you, is how do you determine, the best treatment option for each patient? Because as we know, and you being a provider, being a physician, no two patients are always the same. There might be some variances or differences in terms of what you would obviously notice. But I think that there's also something that's important out there that we talk about when it comes to things like lifestyle changes or medications or medication therapy. With your expertise and in your opinion, is that something that could be looked at prior to a procedure being recommended?
Absolutely. I mean, patients will ask me all the time, um, what's the best way to try to prevent these fibroids from developing in the first place? And part of the problem is we don't have the research behind where fibroids come from. If we knew where fibroids come from, we'd have a much better way to get on the preventive side of the equation. But unfortunately, fibroids are one of the least funded medical conditions. It ranks near the bottom of the most common medical conditions in terms of research funding, and it's really a health inequity that needs to be fixed. There are some legislative efforts currently going on trying to address these things. One of which being the Fibroid Research and Education Act from Stephanie Tubbs Jones. Another is an effort from Senator also Brooks from Maryland. She has legislation also. Both of these bills would increase funding to the NIH and provide important CDC funding to educate physicians and the lay community on some of these less invasive techniques, so we don't do as many hysterectomies as we've done. But if we knew where fibroids come from, that would be very helpful. But again, the research is lacking. But what we do tell patients is there are things that you can control and there are things you can't control. We know that genetically it can run in families. So if your mom had fibroids, you're more likely to have them. You can't pick your parents, at least not currently. So we focus on the things that we can change. While we don't know where fibroids come from, once they arrive on the scene, they grow with estrogen. Estrogen is pervasive. It's in the food, it's in the water. You can't avoid it. However, there are certain hormone-rich foods like red meat, non-organic chicken, dairy that you can limit or try to work around or eliminate. That's going to be helpful. There are also foods that have flavonoids in them. Colored fruits and vegetables have these flavonoids which block an important enzyme in estrogen production. We know that estrogen is stored and produced in body fat. So the more body fat you have on you, the more stimulated, the more extra estrogen is circulating, stimulating these fibroids to grow. And so if you can make some healthy eating choices um, and exercise, lose excess body fat, all those things are going to be helpful. And then the final piece is vitamin D. Vitamin D is the most powerful growth inhibitor of fibroids that we're aware of. But unfortunately, only 10% of African American men or women have adequate vitamin D. So it's really important to get your vitamin D checked, your level. And if you need to be supplemented, supplement, because if you have a normal vitamin D level, you're much less likely to suffer with fibroids.
So that's very interesting, Dr. Lipman. As you said, you can't, specifically pinpoint where these fibroids are originating from. But when you mention things like, weight, medication, lifestyle choices, about the intake of food that we consume as a population, as a community, and how that could impact on you, the levels, in regards to vitamin D, and the fact that that's got a strong correlation to it. These are obviously factors that, people need to consider, and hopefully people don't have to obviously be involved in terms of digressing or having issues that are impacting them when it comes to the fibroids themselves developing.
Yeah, you
So
really have to be more of a, you're the CEO of your own body. You only get one. And people need to get more involved and take a more active role in their health. In fact, I'll see patients that have done more due diligence for buying a toaster oven or an air fryer or a new car purchase than they have on their own health. And we have to change that as well.
yeah, you hit the nail on the head. I think as a society, sometimes those material possessions or what we are wanting or sort of yearning for, should not obviously take preference when it comes to someone's health. But I like how you summed it up by saying you should be the CEO of your own body. I think that's a great statement and very, very relevant in this particular scenario. Um, I now want to move into the actual procedure piece or the treatment option, Dr. Lipman. So can you please, explain probably in layman terms, what is the process of uterine fibroid embolization or uterine artery embolization? And
Yeah.
how is that undertaken by an interventional radiologist or, somebody that is specializing in this particular treatment?
Yes, as you mentioned, the interventional radiologist is the physician like myself that performs these procedures, not the gynecologist. Gynecologists are surgeons, and likely you'll hear only the surgical options that they offer. And it's really important for women to know all the options, not just the surgical ones. They're important, and there's no one treatment that is great for everybody, but you have to know all the options. And so the uterine fibroid embolization or uterine artery embolization, same procedure that's used interchangeably. Um, that procedure is completely non-surgical. It's completely outpatient. So patients will come into our Atlanta Fibroid Center. The procedure takes about 30 minutes to perform. It's very quick. Um, the patients are asleep during the procedure, but they're not put to sleep like surgery. The
Right.
sedation is much nicer. It's IV, intravenous, and local. After the procedure is over, there's a recovery for a few hours, and they're discharged home with a Band-Aid at the top of their right leg where we go in. So the approach is at the very top of the right leg, where the right leg meets the torso. And we can enter with a little tiny catheter into the artery. The catheter is like a piece of spaghetti, and I can steer that catheter into each of the uterine arteries one at a time. Each of the uterine arteries is like a big tree. I'm in the main trunk, in the big trunk of the tree, and then the tree starts branching, getting smaller and smaller and smaller branches till you get out to the leaves. The fibroids are the leaves of the tree, and I know what size those small peripheral branches are, and I
Yeah.
can plug them up. And without a blood flow, those fibroids are going to die. And as they die, they soften and shrink. And as that goes on, a woman's symptoms start to disappear. The big trunk and the main branches stay open. So the uterus is alive. And we've had numerous children born after UFE. I've had multiple twin births. So the uterus is alive, but all the fibroids die. And that's an important concept.
Okay, very well explained about the branch and sort of the leaves from that branch. I think that analogy can play out very well So that's, a good insight for them to kind of understand that. You've actually brought up something quite important because I was actually going to say and ask you next, can women who actually want future pregnancies still be a candidate for this particular procedure of UV?
Absolutely. The chance of a live birth is the same whether you do uterine artery embolization or you do the surgical choice, which is a myomectomy. Myomectomy is cutting into a woman surgically, removing some of the fibroid burden, and that's the Achilles heel of that procedure. And then reconstructing the uterus, close the wound, and wake the woman up. And you never get them all out. You operate, you surgically try to remove as many of the larger ones because they tend to be the ones causing the most misery. But they know that they leave behind a number of smaller fibroids. And so those fibroids, those smaller fibroids that are present when a woman wakes up from her myomectomy, they start to grow immediately. And over time, those smaller ones grow up to become bigger ones. In fact, the recurrence rate for myomectomy is 11% per year. So within 5 years, most women need another something. And I see women all the time that have had 2 and 3 myomectomies, even 5 myomectomies. So the biggest problem with myomectomy is they don't address all of the fibroids surgically. A lot of these women have so many fibroids, you couldn't possibly take them all out. And
Right.
that's a problem because now you've subjected this woman down the road to another procedure where, and some of the myomectomy patients wake up without their uterus. Every myomectomy patient has to sign a medical release saying, you understand the intent is to do a surgical myomectomy, but during the procedure, and these tumors are very vascular, they bleed a lot. If
Right.
they have too much blood loss during surgery or they can't reconstruct the uterus, they're going to wake up without it. And so they have to be prepared for that mentally to wake up without their uterus. But presuming that they have a uterus when they wake up, they have living fibroids in there versus the patient that wakes up from UFE, they have no living fibroids in their uterus. So the recurrence rate for UFE is very low. It's unusual to do a second UFE on somebody. It does happen. We do it. It's usually somebody maybe in their late 20s or 30s. Now we see them again in their 40s or maybe even early 50s, and they've grown new fibroids. Okay. But even then, which is unusual, 2 UFEs, in my opinion, is still way, way better than 1 invasive surgery. And to put a final point on it, if you have a myomectomy at any point in your life, and then you get pregnant afterwards at any point, and you get to
Right.
term or near term, you're going to deliver by more surgery, a C-section. The patients that we've had, as long as they've never had previous myomectomy, our patients that get to term or near term after a UFE typically deliver their full term and they deliver vaginally. So again, another big difference between the two.
It's interesting so much that goes into it. You talk about uterine fibroid embolization, Dr. Lipman, UFE, and then you've got myomectomy, which is the invasive surgery. It's almost as if you're looking at it, neck and neck, and you can see that firstly, uterine fibroid embolization, as you mentioned, is an outpatient procedure that takes 30 minutes to complete. Patients coming in, going back home the same day, no hospital stay required, right?
Right.
Whereas here, you've got an invasive surgery like myomectomy, where they are actually, potentially even at risk of losing their uterus or having these fibroids still reoccurring. And, obviously, that's something that is going to be of concern to them. So, depending on obviously and using an assessment and judging by the case by case basis, for example, for you at your practice, you can determine either. But it sounds to me as if you were given a choice and if you were a candidate for both, that uterine fibroid embolization is the more minimally invasive, more sort of reassuring option than going the surgical route and having to continue having fibroids reoccur down the road.
Well, yeah, there's no one procedure that's great for everybody, but in general, obviously the UFE procedure is much safer than surgery, whether you're talking myomectomy or hysterectomy. It's much less invasive. The recovery is much shorter. Our patients go home the same day with a Band-Aid. For that afternoon and evening, they're in bed or on the couch. The next morning, they're mobile. I mean, there's nothing comparatively on the surgical side for
Right.
that.
Right.
They're in the hospital by the time my patients are up walking around, moving about. They're still in the hospital, a lot of them.
Right.
And so it's UFE is safer, it's less invasive, the recovery is much shorter, and you get to keep your parts. We haven't talked about hysterectomy, but hysterectomy really should be a last option resort because UFE is so good. The success rate is over 90%. So these patients do very well, and they don't need this amputation, if you will. I mean, if you look at hysterectomy, it's the second most common surgery done in the United States, which is kind of staggering because neither one of us have a uterus, and 50% of the population in the United States doesn't have a uterus. Yet it's the number 2 surgery that is performed, and the average age is less than 40. And I've met way too many women less than 30 have already had hysterectomy. None of them wanted it, but these women weren't told about UFE.
Right.
And the number one reason why hysterectomy is performed in this country is not for cancer of the uterus. That would be appropriate. It's for these benign fibroids. So, and women of color disproportionately are affected by fibroids. So the question becomes, why are young women of color undergoing amputations for benign disease?
It's actually interesting you mentioned that because after we spoke about, UFE versus a myectomy, Dr. Lipman, myomectomy, sorry. Now I was actually coming to the next point, which was a UFE versus a hysterectomy. But I'm so happy that you brought it up because, you mentioned something that women would have thought twice had they had that education piece provided to them to realize there is an alternative to a hysterectomy. It wouldn't have been their first choice. I wouldn't kind of sort of regard it as a comparison, but if we were to look at it as almost as having buyer's remorse, where they wish they could keep the option of that, hysterectomy being avoided and being able to fall pregnant again, had they known better, either
Right.
when they were speaking to fellow loved ones, family members, and OBGYN, whoever it might have been that was providing that advice to them, that they realized there is an alternative. So,
Right.
besides being minimally invasive, besides being something that happens in and out, you're allowed to deliver, without having a C-section thereafter if you have a uterine fibroid embolization. There's a lot of those pros and benefits. But I think the major one, as you mentioned, rightfully so, is UFE or uterine fibroid embolization versus a hysterectomy. Because I am sure, if you've seen this firsthand, you mentioned it now, if you go back to a lot of those women that were in a stage where they could, fall pregnant and give birth, if they had a choice to not have a hysterectomy, they probably would have definitely taken this option out.
There's no question about that. I see buyer's remorse all the time. Because again, remember, these are oftentimes young women. I spoke at Tuskegee University in front of several hundred young Black women, and a number of them came up to me afterwards crying. I mean, these were women in their late 20s or mid 20s, had already had a hysterectomy. None of them wanted it, but they were suffering so badly. They have these crime scene like periods, pelvic pain, urinary frequency, these horrible symptoms month after month after month. And they gave in because they weren't told about UFE. UFE's been available for 30 years now. So, and everyone knows about it on the physician side, but the gatekeepers of women's health are all surgeons, and surgeons in general, for the most part, and we work very cooperatively with gynecology, but there are a lot of gynecologists out there that are not explaining that UFE is a great treatment option for them because they're surgeons and they want to operate.
Right.
And a lot of times it's a binary decision on their part. They give the patient 2 options.
Right.
And if they ask the patient, are you interested in childbearing? And if the patient says yes, they are offered myomectomy. And if they say no, they are offered hysterectomy, even though they know about UFE and they don't give them that option. In fact, there was a big study from the Mayo Clinic back in 2013 in the Journal of Women's Health. Elizabeth Stewart, who was the chief of OBGYN at the Mayo Clinic, they looked at about 1,000 women with fibroids, and they were surprised that the majority of these women waited 3.5 years or more to be treated, and a quarter of them waited over 5 years. And the reason why they waited so long and they're suffering, and There are over 1 million women we call the silent sufferers sitting on the sidelines currently, suffering with all these miserable symptoms because they don't want surgery. That was the take-home message from the article. These women wanted to avoid hysterectomy. They didn't want any surgery. They wanted a less invasive option, but they weren't given one. They weren't told about UFE. And again, UFE was endorsed by the American College of Obstetrics and Gynecology back in 2008. We've been doing, UFE since the mid to late 90s, but in 2008, the parent organization of all gynecologists, ACOG, gave it its blessing in 2008. Well, 18 years have gone by since then, and still we're no different than we were 18 years ago. Women aren't being told about these options, and it's a big issue. Women are entitled to know all the options, not just the surgical ones.
Sure. I couldn't agree more. As you mentioned, even though, I've got family members, I've got a wife, I've got, siblings that are, sisters, I've had a mom. I understand that it's so important that, women are given the options, because it's almost unfair when you're dealing with someone's health that there's only one source of, education being provided. You've got to look at the options and look at what's best for you, because at the end of the day, there is a choice, that needs to be made or taken, and it's up to the woman to be able to have that. What I wanted to ask you, Dr. Lipman, is that we kind of touched on this a bit so far in the podcast, but something that we've spoken about and is being very prolific is that women of color, African American women or Black women, is there a particular reason that they are so prone to being the ones that, I know women overall in general are at risk of uterine fibroids, but why is it affecting that particular part of society so much?
Well, it's multifactorial. Genetically, it runs stronger in families of color. And as I mentioned earlier, you can't do anything about the genetic aspect of it. But there are things that women can do. Body fat. In general, African American women have more body fat than other racial groups. Asian women have the lowest body fat and also have the lowest incidence of fibroids. African American women have the highest incidence. Now, it's not all a body fat issue, but it's one component because, as mentioned, estrogen is stored and produced in body fat. So one of the things you do have some control over is trying to be as close to your ideal body weight number, whatever that is. No one says you have to be skinny, but try to lose the excess pounds, excess body fat. That will definitely improve your fibroid symptoms. The other aspect of this, it'd also be good for your cardiovascular health. It's kind of a double win if you can do that. The other piece of that, as I mentioned earlier, is the vitamin D aspect. If you have a normal vitamin D, you're much less likely to suffer from fibroids because it's such a powerful growth inhibitor of fibroids, yet only 10% of African American women do. So that, again, gives them another risk factor to deal with. And we emphasize that when we see patients at the Atlanta Fibroid Center. We want to make sure, get these women to get normal vitamin D levels, try to improve their nutrition, make healthier eating choices, lose excess body fat, exercise. These things will be helpful throughout the process, whether you've had a UFE or not. I mean, it's good to be on that preventative side. And as I mentioned, if you can follow these things and eat healthier, be closer to your ideal body weight, it's going to be much better for your overall cardiovascular health as well.
Right, for sure. In terms of coming back to the actual procedure itself of uterine fibroid embolization, Dr. Lipman, what has been like the success rates when it comes to symptoms relief? And I ask you this is because, I work with a lot of interventional radiologists as well, that have their, UFE treatments in place. And one of the things is after they perform a procedure, they kind of get feedback from the patients. I am aware that especially after a procedure is done, that, there might be a bit of pain and discomfort that the actual, patient has gone through. So is there a waiting period for them that they normally need to look at before they start seeing, symptom recovery? Could they be experiencing a lot of pain straight after? Can you just kind of elaborate on this?
Yeah, well, you touched on a couple of things. The success rate is over 90%. And that if you go to a place that does a lot of fibroid embolization, again, it's available throughout the country, but at Atlanta Fibroid Center, this is all I do. I don't do anything else, and I've done more UFEs than anyone in the country. And so the experience matters because that will lead into not only having improved success rate than other places, but it also has less of the complications or less of the pain that you describe. There are places, even in Atlanta, that do this procedure that really don't care for the patient after the procedure is done, and that's just wrong. And so we have a very specific pain protocol in place at the Atlanta Fibroid Center that begins when the patient walks into our center. And so as soon as they're in the room and an IV is placed, they're getting not only a number of drugs and things that will help in the pain afterwards. And I would say in general, the vast majority of patients that we treat, they will get pain, but it is very manageable. We give pain medicine, as I say, before the procedure, during the procedure, and after the procedure, and send them home on oral medication. And so while we occasionally, maybe one person a month, see somebody that their first evening, they had a kind of a rough go, they come back to the center, get a couple more hours of IV relief, and then have sent them again on their way, and no one has come back after that. So if you're going to see this extra pain, if you will, it's that first evening, and then they know they can come back to our center. Whereas other places, once they've done the procedure, they kind of abdicate their responsibility to take care of these patients. And so that's a real problem that, shouldn't occur. The interventional radiologist should manage that situation. And again, fortunately, in our experience, it's an unusual one.
Great to know, Dr. Lipman. I think it also goes to show the experience factor and the fact that you've done so many of these for so many years. You kind of set the level of expectation and realizing that it's also about the post-op. It's about the recovery, but it's about nurturing the patient thereafter and not just concerning yourself, prior to them coming in, but it's kind of giving them that level of attention thereafter and following through on them in terms of, their pain levels and how their overall health has been and satisfaction. So I think that's extremely important. We've spoken about UFE versus myomectomy. We've spoken about UFE versus hysterectomy. The other thing I'd like to kind of touch upon, Dr. Lipman, is, this idea of fibroids and how it impacts on you versus endometriosis. If you can kind of bring a distinction between those two.
Yeah, well, endometriosis is when the lining cells of the uterus are found anywhere outside of the uterus. So the endometrium is what is responsible for the period. It sheds each month. And when those cells find their way outside of the uterus altogether, and they can be anywhere. They can be anywhere in the pelvis, the abdomen, the skin, the lungs, anywhere. That's endometriosis. Now, there is a form of endometriosis, or in the same family, if you will, that we touched on a little earlier, adenomyosis. That's when the lining cells infiltrate into the muscle, which lies just beneath the lining. By definition, even though it is a sense endometriosis, it's endometrial cells not where they're supposed to be. Right. So in a sense, it is endometriosis, but because endometriosis is defined as being outside the uterus, technically you can't call that endometriosis. They had to give it its own name. They call that adenomyosis. So adenomyosis can be thought of as endometriosis that involves the uterus. Now, we see adenomyosis all the time, and we will treat it just like fibroids. Now, the embolic, the particle that we use, is sized differently for adenomyosis than for fibroids. It's a slightly smaller particle size, and there are some technique differences that we do slightly differently. The approach is all the same. The catheters are the same. The uterine arteries are obviously the same. Everything is pretty much the same, but there are some subtle differences in patients that have adenomyosis only versus fibroids only. Now, a lot of people have both, and we will kind of direct the therapy based on, well, which do we think is more important here? Is it a lot of adenomyosis and only a few incidental fibroids? We'll treat it like adeno. Is there a lot of fibroids and just an incidental focal area of adenomyosis? We'll treat it like fibroids. So, that's where the kind of subtlety comes in. But we treat adenomyosis all the time. Now, endometriosis, when it clearly is outside of the uterus, is a little more problematic. If the endometriosis is very florid in the pelvis, let's say, it's not something currently that we're doing much with. It's really something surgical. But fortunately, we don't see a lot of that.
Okay. Okay, good to know. We've spoken a lot about the diagnosis, the symptoms, the actual procedure for this, condition, Dr. Lipman, but I would like to now kind of, sort of explain a bit more about the patient experience, because that I think is obviously crucial. What do you see with your practice and over the years of, performing hundreds and thousands of these different types of procedures when it comes to UVs? What concerns do most women have? What surprises patients the most after they undergo this treatment?
Well, they're literally transformed. The typical patient I see every day at the Atlanta Fibroid Center is someone that is bleeding horribly, crime scene-like periods, lots of pelvic pain, urinary frequency, waking multiple times each night to urinate. And then they undergo this 30-minute outpatient procedure. They go home the same day with a Band-Aid. And when they come back and see me 3 months later in follow-up, they're a brand new woman. They are completely transformed. You took a woman that basically everything that she did or didn't do revolved around this miserable period, month after month after month after month. And, she's largely been dismissed or ignored, told that she had to have hysterectomy. She didn't want that. So she had to put up with this. She had to just kind of push through. Because a lot of these women, whether they can't afford it, the surgery financially, or they can't afford to be out of work 2 months, because the recovery for hysterectomy and myomectomy, 6 to 8 weeks or more. So they can't do that. And so and they're not told about UFE, so they just push through and suffer with it. Some of the suffering is because a lot of the physicians have kind of normalized what a woman goes through when she suffers with fibroids. These horribly heavy, painful periods oftentimes gets just normalized. Like, yeah, well, you're a woman. That's what comes with being a woman. Or you're 40 now. This is what or your mom was a heavy bleeder. Now that's your lot in life. You're going to be a heavy bleeder. Just kind of be resilient, silly stuff. I mean, this stuff has been normalized. And so these women expect, to just do this, not knowing that we have the answer. We have the journey to complete relief. They're transformed to a completely normal life. I mean, a lot of these women, they're just suffering so badly and they're operating on a very low tank. I mean, they've lost so much blood over the months, slowly so that they don't die, but their quality of life is miserable. They're tired, they're worn out, they're fatigued mentally and physically. And after the UFE, and again in follow-up, now they have a normal iron and hemoglobin, so they have energy they haven't seen in years. And again, some of that is normalized. Oh, I'm 40, I'm supposed to feel tired and weak and run down. This is just part of aging. No, you're running on such a low tank because you're bleeding way more than you can replace iron and hemoglobin wise. And we have the answer. UFE is the answer, but the gatekeepers of women's health has largely kept the answer away because they would prefer to cut people open and operate. And a lot of women don't want that. And, so they suffer, and the suffering is needless and it needs to stop. And I'm glad you're having me on, because every time we speak about these things, hopefully we'll change the dialogue. You had mentioned when we talked offline about Lupita Nyong'o, she has brought a lot of awareness, and this, normalcy has to change. This is not normal.
Right.
bleeding like they're bleeding, and the pain is not normal. And you need to address it. In fact, I tell patients all the time, I go, if your period interferes with your quality of life in any way, I don't care what your hemoglobin or hematocrit is. I don't care what your physician tells you. It's not normal and it needs to be addressed.
For sure. I wholeheartedly agree with you there, Dr. Lipman. You mentioned right now about the fact that there needs to be more education around this, but coming back to the situation where we talk about everyday women can be impacted, as well as high-profile women. You mentioned Lupita, who's an Academy Award-winning actress, such a well-known public figure internationally, kind of trying to create this research around the fact that she's been living with it and being impacted by it. We talk about women like Tamara Braxton, who's a known, singer out there, musician, Portia Williams, Lindsay Davis from ABC, that's come out in the spotlight and spoken about it as a news anchor, and even Sharon Stone, who says she wished back when she was younger that she was given this advice, as you rightfully mentioned, like from an OBGYN, where she could have gone for some treatment like this, when it was impacting and affecting her most in life. So it's important to understand that fibroids do not discriminate. It doesn't matter what walk of background of life you are as a woman, high profile, successful, wealthy, famous or not, it impacts everybody. So in that way, it's so important that we are having you able to discuss this today and bring that education that's needed around it.
Yeah, it's the number one disabler, the number one cause of disability in young women of color, because this strikes young women of color disproportionately, and it strikes them at a time of their life when they are the most productive, late 20s, 30s, 40s. So the most productive part of your life is being significantly impacted by these fibroids. And we could end a lot of that suffering if women knew about UFE.
Mhm.
And so that's where the educational piece has to be. I mean, we've got to educate people about interventional radiologists because we're physicians just like the gynecologist, but we're not as well known. And we've got to educate them about UAE, UFE, whatever you want to call it, this non-surgical treatment option that is, I mean, if you're a candidate for surgery, you're a candidate for UFE, and 99% of the time. So it's not a question of would you be a candidate? Almost assuredly you will. It's not a question of an insurance. All insurances cover the procedure. It's just having to know about it. And again, we're hoping that people will take a more active role in their health, and they'll learn about this tremendous option that's been available for a long time. It's just they need to know about it, and hopefully they will learn about it.
Right. Dr. Lipman, over your illustrious career, and we've spoken about it briefly, about how many years you've been doing this. Is there perhaps one memorable patient story that comes to mind that you'd like to share with our audience today?
Wow. Um, well, there was a woman that we saw many years ago. She was in her late 30s, almost 40 at the time I saw her. And she was suffering horribly, like the typical fibroid patient suffers, with the bleeding and the pain and so forth. And she went to her gynecologist, and the gynecologist said, "You need a hysterectomy." And she was kind of taken aback because she was like a lot of patients, they were just kind of monitoring her fibroids with ultrasounds and yearly exams. And all of a sudden now, after monitoring her fibroids, suddenly all the only option she was given was pretty severe hysterectomy. And she was taken aback by this. And she said, "Is there anything else? I mean, I really don't want a hysterectomy." And the gynecologist said no. And, this is your only option. You need to do this. And so the gynecologist really couldn't understand her reluctance in not wanting to just end the suffering and just submit to the hysterectomy. And he asked her about it, and she said, "Well, I may want to have a child one day." He looked at the chart, he looked at her, and he said, "You're 39, you're almost 40. I mean, you're single. That ship has sailed. And so now I have to apologize for this very crass rude comment by a physician I don't even know. And I'm like, I apologize. I mean, he should never have said that. I'm sorry that he told that to you and saying that, and I don't know if you'll have a child one day, but I do know I can help you. And let's start with that. And so I did. We performed the UFE procedure on her, and all of her symptoms went away. When I saw her in follow up, she was very appreciative. And so she left after follow up, and she met a man not long after. They started dating. They got married. And lo and behold, they had a child. And she sent me this really nice, heartfelt, handwritten letter thanking me and saying how appreciative she was of the care she received and that she was so glad that she didn't do a hysterectomy. And now she has this miracle baby, Jalen. And she included a little wallet-sized picture of baby Jalen, who she called the miracle baby. And it was great. And, we love getting that. We have a whole two bulletin boards full of baby pictures from women that have sent us baby pictures over the years. And it's very heartwarming. It's very satisfying. Our staff loves it. It's our home run in the World Series kind of stuff. And that was great. And then a number of years passed. And a few years ago, there was a knock at the door at the end of the day. And my front office person came back and said, there's somebody here to see you. And I said, is it a patient? Because I thought we were finished seeing patients for the day. And she said, yeah, I don't know who it is. So I walked out, and it was this woman. And it had been, quite a while since I had seen her. And she said, I know you won't remember me, but I was the one that had the miracle baby. And I said, oh, Jalen, right? And she said, yes, Jalen. And she goes, I want to show you something. So we walked outside of my office, and out of the car from the driver's side popped Jalen. He had just graduated high school, and he came in to give me his, high school graduation picture. So I said, oh, hey, Jalen, I want to show you something. Let's go into my office. We walked into my office, and I pointed to his baby picture, and I said, do you know who this handsome guy is? And so now, if you come to the Atlanta Fibroid Center, you can see Jalen's baby picture next to Jalen's high school graduation picture. And so, and I remember her saying, and there was lots of tears and hugs and everything, and she was saying, I am so grateful for you, Dr. Lipman. I was this close to getting a hysterectomy. I was just worn out. I had had it. I was about to give up. And I was this close to getting a hysterectomy. And I am so glad I didn't, because I never would have had my miracle baby. Thank God for you. And it was just very heartwarming. So I will never forget her or Jalen.
Right. Well, that's such a wonderful story with a happy ending there, Dr. Lipman. I think that, that kind of sums it up best, where, if they had not been able to look at the alternative and, sort out in, just before kind of throwing in the towel, so to speak, and coming and seeing you, Jalen would not be here today. She would not be, full of joy and, seeing the fruits of success in her loins, so to speak. So I think that is so important and such a wonderful story that I think a lot of, our audience should take to heart and realize that if, this is the option that is there, and obviously if they're in and around the locations that you are in, they need to be able to give you a call and schedule an appointment to come and see you.
Well, we see people from all over. In fact, we've seen people from not only all across the United States, but outside the United States, because people will travel. Atlanta's a hub. But in getting back to the patient story, it points out the importance of getting that second opinion. Right. Get the second opinion from an interventional radiologist. If you're suffering with fibroids, get a second opinion from an experienced interventional radiologist who treats fibroids, whether they're a candidate for UFE or not. And don't rely on an opinion of a surgeon, who doesn't do UFE, whether you're a candidate or not. Because I hear all the time, well, my gynecologist said my fibroid was too big, or I have too many fibroids, or there's a lot of misinformation, and you can't rely on the gynecologist to know whether you're a candidate or not. You need to get that second opinion from an experienced interventional radiologist. It's so important. And yes, it requires you to get, a referral either, and it depends on your insurance, Sometimes the gynecologist will do the referral. Sometimes the patients can call directly. They don't need to get a doctor's referral. It depends on your insurance plan. But the important thing is get that second opinion, because it's very important to know your options, because hysterectomy is final. There's no going back from it. And, we didn't talk about what happens to women when they undergo hysterectomy. And again, these are young women in their 20s, in their 30s, maybe 40s. It changes a lot of women psychologically, like a man being castrated. It changes them sexually. Loss of libido, loss of orgasm, bone loss. There's a lot of bone loss after hysterectomy. There's a lot of urinary leaking. You take this big fibroid-filled uterus out of the pelvis, and now they leak urine and have to wear an adult diaper. And now there's recent research from Canada suggesting there's increased risk of cardiovascular effects, increased risk of high blood pressure, heart attack, and stroke if you remove the uterus. And the earlier you do that, the worse the risk is. The bottom line is it's completely unnecessary for fibroids and should be the last resort option because of it. There's a lot of consequences to getting your uterus removed. I understand you might not be interested in children, but that doesn't mean you lose your uterus. I hear all the time, oh, my doctor told me because I'm not interested in fertility, I should just have a hysterectomy and be done with it. Well, you can be done with children, but don't be so willing to lose your uterus, because it has significant consequences, which again, aren't often told to the patient before hysterectomy.
I think that's such a good point that you brought up there, Dr. Lipman, because, immediately women think hysterectomy, do not have to worry about giving birth and having a child. But you've, explained it that there's more than just that itself, the bone loss, the issues in terms of their mental state, their physical ability, their sexual health. There's so many factors that goes into it that I think they should not just, take that as the, be all and end all. And I think it could not be overestimated. And you are so right when you talk about second opinion. We see this in so many other subspecialties or other conditions that are being treated. When people are talking about, oh, just go for an amputation of your leg, that's been given to you because you haven't got that second opinion. We're now making it relevant here when it comes to, interventional radiologists, and especially with regards to fibroids, how important it is to have a second opinion. Because as you rightfully said, there's no going back once the hysterectomy is done. That's it. They cannot be reversed. So I think that's so, so important. But I think that this has been a fantastic session. Thank you so much, Dr. Lipman. I think you, in conclusion, have summed it up so well, with that positive story that you mentioned earlier about that particular patient who, ended up having a baby in Jalen, to the fact that you provided the education around, the importance of, coming and getting a second opinion, understanding the benefits of uterine fibroid embolization or uterine artery embolization, whatever you want to call it, and how it is so important that women do not take their health for granted. Fibroid Awareness Month might be once only in every July, but it's something that affects them each and every single day of the year. And with the more education that's out there, it's providing that resource for them to get that understanding. And I'm sure a lot of them are grateful for physicians such as yourself that are getting so involved with the research. And a lot of those people that we mentioned earlier on our podcast that are actually celebrities or high-profile people that are now realizing the importance of these, what can be at very many times debilitating in terms of the pain and how they are obviously experiencing this with their everyday lives. Premenopausal women taking away from their prime, as you mentioned, their 20s, their 30s, their 40s, when there's got so much happening, they should definitely seek out this right type of treatment and be able to, realize they can come to a practice such as yours or a provider that's closer to them.
Yes, it's so important, and do that extra diligence. It's worth it. I mean, there's nothing more important than your health, and get that second opinion. Do the diligence necessary and seek out other opinions, and just don't take the first thing offered, particularly when the first thing offered is such a severe, invasive option with no going back.
Sure. Well, thank you so much, Dr. Lipman. We loved having you as a guest on the Dr. Marketing Agency podcast. And I'm sure you and I will be able to connect down the road, but I appreciate you making the time, and I'm sure it was something going to be very well received by our audience as well. You have a lovely day.
I appreciate the invitation. It was great speaking with you, and I'm sure we will see each other very soon again, if it's at OEIS or some other meeting. And I appreciate the time and hope this was helpful for your audience. And if anyone wants more information, they're welcome to contact me. I mean, there's easy ways to reach me, but our website is atlii.com. We have an Instagram page, dr underscore my last name, dr underscore Lipman. And then if they want to watch me actually do a UFE procedure, they can go on our YouTube channel, Atlanta Fibroid Center on YouTube, and then find the video. It's something like Watch Dr. L do a UFE or something along. They'll find it. It's a 38-minute video or so, because the 30-minute procedure takes a little longer when you're talking each step of the way, but it's very easy to watch because it's not gory like surgery. It's not like pimple popper or gross. It's very easy and simple to watch. And a lot of patients have said they really appreciate understanding the UFE before they undergo it.
Well, thank you so much, Dr. Lipman. You have a lovely weekend and take care.
Thanks very much.
Thank you.
Bye.
Bye-bye.